Hi everyone, we're going to talk about CT temporal bone, and I'm going to show you my basic approach to CT temporal bone. And this is for somebody who has never really done this before, and for uh, residents who are coming on your first head neck rotation, and you might find this subject somewhat daunting. The problem is that there's a lot of anatomy to learn in this small area. We all learn this in medical school, different parts of the temporal bone, and I think for me, when I first started doing temporal bone, and I find the anatomy is not easy at all. The problem is that when you try to learn this stuff on your own, all this 3D anatomy, the challenging for us is how to translate those 3D anatomy into 2D image that we see on image every day. So one of the strategy that I did, I think many people do, was find a template that you like or the template that everyone uses, and just try to go down the template and maybe talk about the structure, look for the structure that's mentioned in the template. Now, this is one of the templates that I find in our system. So some of the stuff that you know very well, external auditory canal, tympanic membrane, you know this before you do radiology. But other stuff we all learn about in medical school, we may or may not remember too much about it, like ossicle inner ear structures. Then we come across some terminology that's not all that familiar to me before I started, like scutum, Prusac space. What are they? Why are they important? Why do we include them in the template? In this particular template, we also give a pertinent negative of certain pathology like labyrinthitis ossificans and otospongiosis. So let's walk through this template and just talk about how we approach CT temporal bone. You probably get a sense that just from this template, we're going to break temporal bone roughly into three parts, namely outer ear, middle ear, and the inner ear. I think that's a good approach that a lot of people use. Essentially break them into three parts and then approach it from outside and in. My recommendation is that for your inspection and for your dictation, focus on one side at a time. Don't jump back and forth. So start with right side or left side. That way you don't get yourself confused or you don't get your readers confused. So let's get started. So let's talk about outer ear first. To me, this is the least interesting part of the temporal bone. Basically, clinician can see a lot of structure better than we can. So outer ear, external auditory canal. As you remember, the boundary between the outer ear and the middle ear is going to be the tympanic membrane, the eardrum. And when you do your CT temporal bone, always bring coronal and axial side by side and put on a reference line so you know exactly where you are. The first structure that we'll come across for the tympanic membrane is its superior attachment. It is this sharp bony projection, so scutum. That is the superior attach of the tympanic membrane. The tympanic membrane, as you remember, has two parts. There's a very small part on the very top next to the scutum called pars flaccida, the flaccid part of the tympanic membrane. The remainder of the membrane is going to be pars tensa. You can see those very well in the otoscope. A small part of pars flaccida on the top next to the scutum. Rest of them is pars tensa. And when you look at the axial view, the external auditory canal, as you see, has two components. There's collagenous portion and there's a bony portion. Again, not the most interesting portion. Clinician can see this pretty well. Often, though, you will see a small non-specific opacification. You just mentioned it that there's a small non-specific opacification, most likely cerumen. Recommend visual inspection. Certainly, if you see a mass lesion with bony erosion, and you want to draw attention to that, because that could be a skin malignancy, for example. But most of the time, it's going to be just cerumen. On the coronal view, you can see the same thing, collagenous portion of EAC, bony portion of EAC, and look at how sharp the scutum is, and try to locate where the tympanic membrane is. And mastoid is really not part of the outer ear, but I just grouped it in here just because it's right there. It's probably just convenient to look at them at the same time. So for the mastoid air cell, you want to make sure that they are well aerated, pneumatized, and the bony air cell subtiles are intact. At the very top, as you can see at the epitympanum, you can see that there's a direct passage between the mastoid antrum into the attic or the epitympanum of the middle ear cavity. So this is literally the passage to mastoid entrance, addus ad entrem. Make sure that's well aerated. So that's kind of roughly the outer ear part. As far as mastoid, if patient has a history of mastoidectomy, you can generically talk about two types of mastoidectomy. One is canal wall up, the other one is canal wall down. How to determine what they are? It's pretty easy. Just look for the bony wall or the posterior wall of the EAC or the anterior bony wall of the mastoid. For the mastoidectomy, if they take down that bony wall, this is a canal wall down mastoidectomy. If the wall is intact, it's right here, there's mastoid cavity, then you have a canal wall up mastoidectomy. So next time when you see mastoidectomy, you can talk about canal wall up or canal wall down mastoidectomy. So that is outer ear. The second part gets more interesting. You have middle ear. So what are the structure that we need to talk about in our template and we need to inspect? First of all, look at the tympanic membrane again. The very top, the attachment point of the tympanic membrane is this sharp scutum. And right next to that, the small part of the membrane, pars flaccida, the rest of the membrane is pars tensa. So let's talk about different part, the things that you should inspect and mention in your report. First of all, we should break the break the middle ear cavity into three parts, three space. The epitympanum, also referred to as attic, mesotympanum, and hypotympanum. So what are the boundaries between those spaces? If you draw a line between the tip of the scutum all the way across to the facial nerve canal, represented by this little dot, you can always find the tympanic segment of the facial nerve sitting underneath the lateral semicircular canal. If you draw a line across, above is epitympanum or attic, below is mesotympanum, and if you draw a line below the inferior attachment of tympanic membrane, roughly parallel to the floor of the external auditory canal, that's hypotympanum. So hypotympanum is a small space right here, not a lot of important structure in here. So other stuff that you can inspect, especially on the coronal view, is tegmen tympani, which is the roof of the tympanic cavity. Make sure that's intact and not dehiscent. And also cochlear promontory. And another space that you should be looking for is right next to scutum is a small space called Prusak space. It's that small space right between scutum and the adjacent ossicle. For those of you who does not like eponyms, this entire space is referred to as lateral epitympanic recess, and the very inferior portion is the Prusak space. And we will talk about why we need to inspect this space and why we need to mention about this space. Tegmen tympani, we talk about that, the roof of the tympanic cavity, make sure that's intact. And the cochlear promontory is this promontory that's formed by the basal term of the cochlea. It's an important landmark because certain pathology likes to go there, so it's important also for differential diagnosis. So those are the spaces: Prusak space, scutum. Make sure you inspect them all the time. Then let's turn our attention to ossicles. As you remember, ossicles are three parts. It has a malleus, ingus, and stapes. In this nice diagram from Star DX, you can see malleus, ingus, and stapes. If you look at them individually, malleus has a umbel, the very tip, this part's called umbel, connected by handle or manubrium, two processes, a neck, and the head of the malleus. This is something that clinician can also see, such as the umbel kind of sitting right in the middle of the tympanic cavity or tympanic membrane, connected by its handle, manubrium, lateral process. In this case, you can also see chordae tympani nerve, and the small portion pars flaccida, and the rest of them pars tensa. So that's malleus. Its connected next bone is the ingus. Ingus has a horizontally oriented short process, body, vertical oriented long process. The tip of the very bottom of the ingus is the lenticular process, like a small cup. That's a connection or the junction between ingus and stapes. For stapes, you can see the head, bilateral crura, and foot plate, and the foot plate is flush against the oval window. As you remember from college, medical school, the function of the ossicle is when you have a air pressure that's vibrating the tympanic membrane, that will in turn translate into a mechanical vibration, and the three ossicle can amplify that action, and the foot plate is vibrating the oval window, then causes the fluid to transmit spiral up and down through the cochlea, and finally you get decompressed out of the round window. So the relationship between the oval window and the round window is oval window is at the top, round window is on the bottom. Again, in this nether diagram, you can see the foot plate is flush against the oval window, and the round window is inferior to the oval window. On the axial view, if you look from top down, on the axial view, the ossicle or the head of the malleus and the short process ingus has that famous ice cream on ice cream cone appearance on the axial view. So for the axial view, you can see the configuration of the ossicle in general is ice cream, which is the head of malleus, ice cream cone, short process of ingus. So you should have this ice cream on ice cream cone appearance. Make sure that they are not melted together. Make sure that ice cream does not fall off the ice cream cone. So ice cream on ice cream cone, followed by two dots. The posterior dot is the long process of the ingus, and two dash. The posterior dash represented right here, you can see the lenticular process, and you can see the crura, and the foot plate is flush against the oval window. So on axial view, the oval window is not that easily seen. You just have to find the foot plate and you know where the oval window is. Look more inferiorly, you can find the round window. The round window is very easy to locate it. Just find the basal turn of the cochlea, and right at the edge of the cochlea, you will see the small indentation as if there's a small air pocket. That is the round window. So make sure the oval window on the top, round window on the bottom, make sure they are well aerated. And other structure that you can see cochlear promontory on the axial view. Again, find the basal turn of the cochlea is this promontory that's forming of this round bone structure. It's an important landmark because a certain pathology likes to go there, and it's important for differential diagnosis for real life and for board exam. Some structure that's mentioned in our template is facial nerve recess or facial recess and sinus tympani. So where do you find them? It's in the posterior aspect of the tympanic cavity. You can find this pyramid. Notice that the pyramid, there's a small round lucency with it centrally or soft tissue density. That's a muscle, that's stapedius muscle that attached to the stapes, and that function as a sound dampening. And adjacent to that dot, you can see another dot that is slightly lateral to the stapedius muscle. That is a facial nerve. So the deep to the facial nerve is this recess called the facial recess or facial nerve recess. And more medially to the pyramid is the sinus tympani. You want to make sure that they are well aerated. You can imagine because of those important structures, facial nerve, stapedius muscle, and the tendon right here, this is not a location that surgeon can get into very easily. They have to be very careful about all these important structures right here. So sometimes cholesteatoma may be left behind or hiding within this small crevice. So when you are looking at cholesteatoma, make sure that this area is not opacifies, because they can serve as a potential hiding space for residual cholesteatoma. And on the coronal view, what does the ossicle look like? The ossicles from more laterally, you can see the head of the malleus and the umbels right here. As you scroll more posteriorly, you can see the junction between the head of malleus and the ingus right here. The ingus then will take this nice sharp 90-degree turn, just like in this diagram represent. You can see the lenticular process. The stapes will represent a straight line that's go directly extending into this indentation, which is the oval window. So on the coronal view, you can see oval window very well, and you want to make sure that it's well aerated, not opacified. Another important structure of note, see that little dot just right outside the oval window? This little dot right here is a facial nerve or tympanic segment of the facial nerve. It is reliably sitting underneath the lateral semicircular canal. The important thing about this in relation to oval window is that you want to make sure that it's sitting outside of the oval window. Once in a while, there's aberrant anatomy that you can see the facial nerve that is present within the oval window. When that happens, you want to draw attention to it, because in the future, let's say a patient have a surgery or is going to have a surgery for prosthesis placement of the stapes. It would be nice if the clinician knows that the facial nerve is hiding in there. So you want to make sure that you draw attention to that aberrant anatomy. On the coronal view, the cochlear promontory is also very well seen right here. Again, find the basal turn of the cochlea, which look like a snail on the coronal view. Basal turn forms this nice promontory. And I will show you some example of what pathology you like to go there, and that's important for board exam. Again, scutum, Prusac space, tegment tympani, and all those structures that you should be able to inspect individually. Okay, so let's show a couple pathology as an example of what we are looking for. This is a rare case that you probably won't see again. In fact, I never seen in real life. This is coming from AJNR in 2007. A case report of somebody has a bilateral hearing loss after lightning strike. Here you can see the configuration of the ice cream on ice cream cone, just for normal reference. Normally, as you remember, ice cream should be sitting on top of ice cream cone. In this case, the ice cream has fell off the ice cream cone. This is a rare case of bilateral dislocation of ingus and stape and malleus. This is a pathology that you are likely to encounter though. This is one of the most, actually the most common middle ear lesion. Here you have an example of 15-year-old patient with left-sided conductive hearing loss. Clearly, when you compare left to right, the left is abnormally opacified. A couple things of note. Number one, the scutum is blunted. It's not as sharp as the other side. Maybe on this image it's a little bit more difficult to appreciate, but the blunting of the scutum is present. Remember, adjacent to the scutum, that's Prusac space. In this case, it's completely opacified and expanded. In fact, the entire middle ear cavity is abnormally opacified. Then the patient also has a MRI. The most important sequence for that is going to be diffusion-weighted sequence. You can see there are two types of diffusion-weighted sequence that we do. One is your standard EPI. This is the same one that we use every day for brain MRI, looking for stroke. This is a special diffusion called haze diffusion. The reason why you want to use haze diffusion is that for EPI diffusion, this is something that we use all the time. When you're looking for brain pathology though, that's not a big problem because there's not a lot of susceptibility artifact within the normal brain. However, it is also EPI is a technique that's very, very prone to susceptibility artifact. So areas such as air generate a lot of susceptibility of blooming artifact. You can see that usually just ignore this finding, right? You never call that's the acute infarction in the temporal lobe because that's a susceptibility artifact. That in turn, if you have an area that you're looking for has a lot of air or susceptibility artifact like mastoid air cell, it's going to obscure anything that you try to find. So therefore, we try to use a technique that's not as prone to susceptibility artifact. We use a non-EPI diffusion, in this case haze diffusion. You can see the lesion much better. So this lesion shows restricted diffusion. So now I have just give you all the buzzword description about this classic finding of this pathology, namely blunting of the scutum, opacification and expansion of the Prusac space or the entire lateral epitympanic recess, and sometimes you can see bony erosion of the ossicle or adjacent bony structure. Lesion shows restricted diffusion. This is a classic example of Cholesteatoma. And this is something that you need to know for real life and for board exam. It is one of the most common middle ear lesion. This is acquired Cholesteatoma. Let's just do a quick review about the structure and why is it important that we talk about them on our report. The scutum, the Prusac space. So remember, the scutum is a superior attachment of the tympanic membrane. And also remember, adjacent to that, that's pars flacida, so the flaccid part of the tympanic membrane. And sitting on top of the pars flacida is the Prusac space. And here again, illustrated on this cartoon. So what happens is that when you have a recurrent or chronic middle ear inflammation, you're going to block the outlet of eustachian tube. In that case, you're going to generate a lot of negative pressure within the middle ear cavity. So guess which part gets sucked in first, the flaccid part or the tense part? It's going to be pars flacida. So the pars flacida begin to retract and forms a pocket. Recall the tympanic membrane, the outer layer of tympanic membrane is covered by skin. So now you have a retraction of a skin covered pocket. So essentially, you're going to start have the skin that's continue to be exfoliated. So you have accumulation of all this exfoliated keratin debris. In other words, you have skin growing in the wrong place. That sac can continue to expand, and you can continue to accumulate. And also, that serves as a very nice culture medium for bacteria and infection. So patients going to continue getting a recurrent infection in this pocket, and that causes a lot of erosion. So Cholesteatoma is not a neoplasm, but it does cause a lot of local erosion or bony erosion. So the first thing that they tend to erode, of course, is scutum. So therefore, you make a comment about, if you see opacification right here, whether or not you have a blunting of the scutum. In other words, if you say that you're worried about Cholesteatoma, and the first place I tend to feel is the space that's right next to it, so that space is going to be Prusac space. And in this case, that they can continue to expand, of course, and cause erosion of other bony structures such as ossicle, such as superiority into the tympanic roof or tegmen tympani, and sometimes can also expand all the way across, causing erosion of the lateral semicircular canal, etc. This is a nice cartoon diagram from StatDX, just illustrate the whole thing. There is a breakage or a pocket in the pars flacida. You can see there is blunting of the scutum. In this case, there's erosion into the lateral semicircular canal and almost erosion through the tegmen tympani. This is a real-life example that almost corresponding to this cartoon. You can see blunting of scutum, marked expansion of the Prusac space. You can see a very thinning of the tegmen tympani and erosion through the lateral semicircular canal. Also, you see that the ossicle is almost entirely eroded. So, Cholesteatoma. So whenever you suspect that, you can also recommend doing a haze diffusion on MRI sequence, looking for restricted diffusion. On direct visual inspection, again, you can see that nice retraction pocket of pars flacida. There's a lot of scarring right here, and the Cholesteatoma on imaging is describing as pearly white. And the complication, of course, is erosion through various structures such as lateral semicircular canal. Sometimes can erode through the facial nerve, tympanic segment of the facial nerve canal, and of course through the roof of the tegmen tympani. And as I mentioned earlier, this can also serve as a nice culture medium for infection. So patients tend to come in with recurrent infection. What about this case? While we talk about the importance of cochlear promontory, remember that's a promontory formed by the basal turn of the cochlea. So whenever I see a focal lesion sitting right there, especially for board exam, think about three lesions, or mainly two differential diagnoses. One is congenital cholesteatoma. Unlike the last case I just showed you, that's acquired due to chronic inflammation, acquired cholesteatoma. Sometimes you can have a congenital cholesteatoma without prior infection. And this essentially is the same as epidermoid. So if you see a focal lesion sitting right at the cochlear promontory, so think about congenital cholesteatoma versus paraganglioma, specifically in this location is referred to as glomus tympanicum. And sometimes a barren vessel, you can see that as well. And in real life, you should be able to follow the entire vessel. But on the board exam, when they give you just one images, also think about a barren vessel, potentially. So this is a case of a 52-year-old female with right-sided post-out tinnitus. You can see that there's a lesion, first of all, cochlear promontory. You can see a focal lesion that's sitting right on the cochlear promontory. So my differential diagnosis right now is going to be congenital cholesteatoma versus glomus tumor, paraganglioma, very vascular tumor. So how do you differentiate them apart? They look different clinically, and also on imaging, the vascular tumor should enhance. This is probably hard to see, but you can see that there's an enhancing focus. You don't see it on the other side. So this lesion does enhance. So therefore, this is not cholesteatoma. Rather, this is a vascular tumor. This is a paraganglioma or glomus tympanicum. If they are big enough, you can do DWI. With cholesteatoma, which is basically epidermoid, you should see restricted diffusion. But with vascular tumor like this, you should not see restricted diffusion. So that's another way to tell them apart. For the purpose of if the differential diagnosis for post-out tinnitus, you can think about vascular cause, or you can think about a vascular tumor. So in this case, a glomus tumor. So that's a differential diagnosis. You can see that. And then the if you see enhancing lesion, sometimes you can also think about schwannoma if it's close enough to the facial nerve. As a companion case, so the last case right here, the enhancement, vascular tumor, focal lesion sitting on cochlear promontory, that's glomus tympanicum or paraganglioma. As a companion case, you can see another focal lesion. This one's rather large, sitting on the cochlear promontory. And when you give contrast, which I don't have images to show you, this lesion does not enhance. If you do MRI with diffusion weighted sequence, this lesion shows restricted diffusion. So this is congenital cholesteatoma. Also, it basically is the same as epidermoid. So clinically, that's what they look like. This from New England Journal of Medicine has a nice illustration of cholesteatoma is what they describe as pearly white, and glomus tumor is a vascular tumor, so it's going to be angry red. And this one will present with a post-out tinnitus. In theory, cholesteatoma should not.